So a very warm welcome to everybody to this seminar on women's health. Um, Somebody may ask, women's health is something that's been often discussed. The gender-based inequalities, they are visible across social and economic sectors. There is no, this chair's over there. There's no major headline there. But there's a lot that's changed over a sense of a change over the last several years, which actually really necessitated a deep focus on this. Everybody's well aware of the gender inequalities within the health sector. For long, the policy response in India with regards to women's health has focused on maternal health, and which basically means it focused on women of reproductive age and not looking at the whole gamut of health challenges through the life cycle, but really a very limited set of health challenges. Of late, that seems to be shifting to some extent with a slowly growing maybe, recognition of the increasing burden of NCDs, of the increasing burden of mental health. At the same time, while the challenges of maternal health, communicable diseases hasn't quite reduced, it is certainly improved, but not, it's still much worse than it needs to be. So which is why, a lot more attention needs to be given to women's health, because while we may think that policy responses and the budgets and spending would be gender neutral, in a sense, in reality, they're not. And therefore, it needs to be understand what is happening, why it's happening. There were three prime questions that we thought needed attention to begin with. What is the gender differentiated disease profile? Having a good understanding of that. Related to that is the gender bias, if there is, in healthcare access, which basically means in what way is the health system, and implicit within that would be budget's expenditure, responding to women vis-a-vis, let's say, men. And the third would be, given that predominantly the policy response in India, at least now, is in the form of insurance, how are women responding to that? Or rather, to what extent is that response addressing women's needs? So there is a changing disease profile. There is a certain access to healthcare services, to health insurance. Is there an alignment? Is there an alignment between health needs and between what women are accessing healthcare and health insurance for? So those were sort of, for starters, opening questions, which is why we organized this panel. CSEP has done a little bit of work. We hope to do much more in this. And, building on that work, we've got this brilliant panel here today who will be focusing on these questions. And in the process, I hope, highlight many more questions that need research, so that as CSEP moves forward in our agenda of looking at women's health, at least some of those questions will emerge today on what are the critical questions that are important from the research point of view that are not getting enough attention. So with that, I have a few questions, but we will come to that later. So I want to introduce our brilliant panel today. Online, we are joined by Radhika Jain. Thank you, Radhika, for taking the time out and joining us online. She's an assistant professor of health economics at University College London, which is an affiliate of the UCL Center for Global Health Economics, and she's been invited researcher at JPAL South Asia. We have Sapna Desai, who's a senior fellow at the Population Council Institute and co-chair of the Global Journal of Sexual and Reproductive Health, MATTER. Nandita Bhan, who was until recently a visiting fellow at CSEP and who's the one who did that study along with Prajakta. Nandita is professor at the Jindal School of Public Health at OP Jindal Global University. They will make one presentation each, not three presentations each, which will be discussed or commented upon by Anjana Bhushan. Anjana was until recently with WHO, leading their work on gender equity and human rights across many countries, Southeast Asia, or all countries, Southeast Asia, all countries, Southeast Asia. So comes with deep insights on what's happening beyond India. So let's start with these three presentations, hopefully 15 minutes each, with Anjana 15 minutes, and then we open it up for questions, etc. So with that, I'm going to request Nandita to start, just focusing on who's presenting what. So there's a kind of a flow in the discussion. Nandita, over to you.
Okay, my slides are, I don't know if there's I can move them, but they're not on the screen. No worries. Yes. Is it possible to minimize that tab so that people can, yeah. Okay, so thank you. Firstly, I just want to acknowledge Prajakta, who's my co-author on this work, and obviously Sandhya for her vision and sort of, in commissioning and thinking about this stream of work in general. Just to set the context a little bit, I think we all know, and perhaps we all agree, and that's, we all in this room who agree that despite economic and technological progress, gender inequalities are some of the most resilient challenges that we face today. And, these are cross-cutting. They affect all the achievement of all SDGs and all our development goals. In the health sector, there's been a lot of discussion of UHC, universal health coverage, but largely when we sort of bring it down to sort of what it actually means, UHC has really meant an insurance-centric model, insurance being the instrument for providing healthcare access. And as is well known, health being a state subject, several states have had health insurance schemes that are available to all populations, and these are states that are called brownfield states, while there are states that are greenfield states that have only recently sort of come into the health insurance sort of game. And I want to say that the national mandate has really changed with the PMJ as enrollment has grown. I just want to say that as a context to what I'm going to sort of be speaking about later. I also want to bring to attention the fact that over the past 20 years, we've been sort of talking a lot about the epidemiological transition. This transition that India and many other middle-income countries have been facing, where the disease burden has really changed from infectious to chronic diseases. And we know that these diseases affect sort of the poorest and the most vulnerable populations of all. So we know that financial risk protection is also an important instrument, but of course the jury is still undecided on how much has that really helped. I think there are a number of studies that have shown that financial risk protection actually has led to increasing healthcare access for all households. But we know that in fragmented health systems like what we have in India, that there can be mixed gains. So inpatient sort of healthcare can go up, while other costs like transport, diagnostics, medication can, still not be covered. Right. So the jury has been undecided, but we know also that these risk protection schemes, there are vulnerabilities within the household. So who gets healthcare within the household is an important element. I want to talk about the fact that, again, something that has been something that we do discuss, but there hasn't been enough research on, which is that health-seeking behavior of women is quite complex. It is influenced, as we know, by a number of factors at the level of, women themselves, their own agency, their own empowerment, family support, community factors, and also their experience and interactions with the health system. We know that there are, health-seeking norms, culture, a lot of these things that actually really play out in enabling or not enabling women to seek the healthcare that they need. But our understanding of these drivers often tends to be quite limited. So we also know that increasingly financial risk protection schemes, as they are sort of increasing their footprint, we know that enrollment doesn't guarantee a lot of access. There are a range of barriers at the level of implementation, awareness, recognition that healthcare is needed that can really influence the way women seek healthcare. So, coming to sort of the point, our paper essentially was really a landscape paper. It had sort of one core question, which was, how does the disease burden and the gendered nature of the disease burden, how does sort of that compare to what women access healthcare for? So what we tried to do was we tried to map the disease burden of NCDs. I think our interest was particularly on NCDs because there's been so much focus on, reproductive health, that we thought that we wanted to also engage with, questions around the epidemiological transition and how it's affected other health conditions. So we mapped the disease burden across men and women over the past 2 decades. We try to assess the barriers to women's health seeking from the data as well as from the other research that was out there. We try to examine the role of women's empowerment indicators and their sort of associations with access to insurance. And finally, we were really interested in state case studies. And within that, we used claims data from Meghalaya to understand, how are gender inequalities operating in a state context that is otherwise seen as somewhat more gender egalitarian. Meghalaya has sort of that reputation. So how do gender inequalities play out there? Just to set the context also a little bit more conceptually and theoretically, in this paper, we worked with a sort of a theory that many of you are very familiar with, obviously. It's a theory that gets used a lot within maternal mortality literature. It's called the 3 delays model. And the delays are really about delays in seeking care. So the first delay is about the gendered, dynamics that play out in the household that sort of restrict women from going out there or even, vocalizing that this is something that they need. The second delay is delay in reaching a healthcare provider. So aspects related to decision making, the role of distance, the role of choice of provider, and so on. And the third delay is once they've reached the healthcare provider, what role do financial factors and other factors related to the health system, what role do they play out? So the objective was really to locate what we were doing within a conceptual framework as much as possible within this model. Just to clarify about the data, so we used 3 major sources of data for our work. We used the India state level burden of disease study. This is a public good that's available for researchers to understand the disease burden. And we sort of looked at this data between 2000 and 2018, so over 2 decades. And we identified several points, sort of roughly 5-year intervals, to get an understanding of the change over time. We focused particularly on non-communicable diseases. And I think for those of you maybe not so familiar with what NCDs are, I think we focused on cardiovascular diseases, cancer, chronic respiratory diseases, and diabetes and kidney ailments. We also used the National Family Health Survey to understand the health seeking side. This is individual level data that is available for perhaps a slightly younger age group, 15 to 49. But the idea was to understand to get a sense of women's voice and their health seeking. And finally, we were able to access Meghalaya health insurance scheme data, which was claims data that was available on the state health portal. And I just want to sort of acknowledge the fact that having more data enables more research and better decision making. So we're really grateful that this data was available out there. And we used this data between 2019 and 2022 to look at the claims available and what sort of story were claims data showing us. I'm going to quickly perhaps walk through the findings. So on the disease burden side, we have looked at, and I think the paper is there, but so I'm just going to sort of summarize some of the key elements from the disease burden analysis. But we found that women reported higher mortality or deaths from cancer, neurological diseases, and diarrheal diseases, but reported equivalent rates of CVDs, respiratory diseases, diabetes, respiratory infections, TB, unintentional injuries, and HIV. So I think the fact that we find these sort of disease categories was very informative, particularly for cancer and sort of some of the data that I'm going to show you in a minute. But also, I want to point to the fact that there has been a larger narrative around CVDs where women and men show equivalent rates. And for the longest time, cardiovascular diseases have often been seen as a male disease, right? And so, in some ways, finding equivalent rates is not necessarily a null finding. It's actually showing that it's not a male centric disease. When we looked at morbidity, we found, and this is in DALIs, but we found again that women reported higher morbidity burden from cancer, nutritional diseases, musculoskeletal diseases, and diarrheal diseases, while women reported equivalent burdens from chronic respiratory diseases, unintentional injuries, self-harm, respiratory diseases, and TB. So again, I think when we start to, I mean, we only did national level analysis, but I think it would be very, very helpful to have more state level disaggregations to understand where different states are in this sort of larger scenario. I want to point to two sort of disease categories, which are particularly, I would say, disturbing and worrisome. One is obviously the notable rise in cancer among women. We here only plotted sort of the top 5 states that have shown the largest change or the largest increase in this time period. And this is not to say that other states are not affected, but these are just the top 5 in a sense. And we see that there has been quite a significant change in the percentage of mortality from cancer in Mizoram, Meghalaya, Himachal, Karnataka, and Haryana. So kind of there's no clear pattern, but it's sort of all over. And we also see that there's been a somewhat slow but gradual rise in DALIs. And I think mortality and DALIs can tell you, or the difference between mortality and DALIs can sometimes tell you the difference between who is getting care and what states perhaps need to do more to avert the mortality burden. Similarly, I want to talk just for a minute about chronic respiratory diseases. And we found that there were quite remarkable changes in Himachal, Rajasthan, Uttaranchal, Jammu, Kashmir. And when we first saw it, we thought, oh, these are clean states, they're hill states. Why should they have chronic respiratory diseases? And maybe the story here is around, indoor air pollution and around, the burden that women face from cooking and from sort of inhaling unclean sort of fuels, right? And so on. So similarly, we found a change in morbidity across those states. I want to point towards NFHS and the findings from NFHS. So this is actually among younger age women. Yeah, too fast. This is among younger age women, 15 to 49, and this is self-reported barriers to their health seeking. And honestly, our own hypothesis when we started was that women would say, oh, the greatest barriers are within home, partner support, family support. But we in fact found that the biggest barriers women reported was an underprepared health system, lack of female providers. And that is again a gender and health system question before us. We found in the work that has been done, I think there are also implementation challenges in the ways that health systems provide for women. So things like, lack of empanelment, expiry of cards, higher waiting times, lack of providers, and also women being sort of rationed out of healthcare within their own home. So when it comes to the question of who is a priority, women are not the priority, it's the husband or the child. So there were several of these factors that operated. I quickly want to point towards another set of findings, which was around access to insurance. So women self-reporting that, yes, they have insurance. And on the left-hand side, I think the darker states you see are states that are brownfield states. These are states that have had existing health sort of schemes. Not surprisingly, more women report access. While on the right-hand side, the map is just telling you new enrollments that are happening with PMJ. This data now I feel is a bit dated because it's from November 2023 and the scheme is fast reaching enrollment. But I think at the end of the day, we have to understand that enrollment doesn't mean access. Enrollment just means, that the coverage is growing. But are women really accessing? That's a question for future. Okay, and the final piece I want to talk about is the Meghalaya piece. So for Meghalaya, we were sort of fortunate to get claims data from the state website, and there was a lot of painstaking categorization into the same categories as the India state level, disease burden. But what we found is that women, reported or we found higher volumes or amounts claimed by women for the treatment packages of hemodialysis, gastrointestinal surgery, basically more generalist sort of procedures, but women reported lower claims for oncology, for neurosurgery, for cardiology, which we are somewhat more specialist procedures. And I think Radhika later on is going to speak to something similar perhaps, or connected, that she found in a different state. I just want to leave. I know I may have like overshot my time, but I want to just say that honestly, doing this piece of research and doing this landscaping raised more questions than it actually addressed or solved. But I just want to leave a few questions out there. One was looking at the state context, which in a country like India, where, the state really matters, I think is a really important question. The second question is around the delays, kind of going back to how do delays affect women's health status and also their clinical outcomes. I speak to a lot of physicians, and a lot of them tell me that, yes, I think women are coming late for cancer care. So, why are those delays happening? I think those need to be understood at the systemic level. I think the third question is that given we know the financial, the women's sort of economic engagement in the labor force market, when women are dependent on others for their healthcare, access, what kinds of dependencies play out? I think that financial sort of side of the question of looking at insurance with and without insurance needs to be addressed. I didn't speak too much to the empowerment question. I think that's for another presentation, perhaps. But I think the final question that I want to leave with is that our health system itself needs to be a bit more gendered. We need more female health providers. The interactions need to be more gender sensitive. So, how do these softer processes that improve quality of care play out? So, I think I'm going to stop here, and I over to my other panelists. Well,
Thank you, Nandita. Thank you. Perfect. 15 minutes exactly. Yes. And I think that's a great overview. Thank you so much. We move to Sapna. And then come to Radhika, who's going to look at the specifics of it. So, yeah.
Perfect. So thank you, Nandita. And I think I'm a perfect act to follow because I'm going to pick up on some of the things you discussed in a broader sense in a very specific case. I think that illustrates a lot of the issues that women face in terms of access to healthcare and also barriers. Now, I titled this very specifically around not just reproductive because I wanted to highlight the importance of thinking about women's health through the life course and the specificity of women's life course models, because often, I mean, they're considered just looking at ages, which is really not the case. And this is not working. No? Oh, okay. Oh, it's changed the font bizarrely. Okay, that's fine, thanks. So I'm going to talk about three things. So one is just thinking about health and illness through the life course, looking at a different data set that Nandita did, and focusing on the life course and the importance of connecting reproductive life health events to later health outcomes in women. And then third, really focus on the case of early hysterectomy in India, because it really illustrates and encapsulates many of the issues that we've spoken of. Now, first, when we think of the life course, and I purposely used a British photograph because this is the sort of model often when we think of the life course, that they're life stages, that they're specified by age. So there's infancy, there's childhood and adolescence, the working age, and then older people, and we all follow a similar course. But what we've seen in our research, which I'll bring up in a bit, is that these transitions are actually not really marked by age, but rather in specific transitions, particularly for women, and particularly what we've seen in India around specific life events, pregnancy, sterilization, menopause, etc., which happen at very different ages. And we find this varies, of course, by group, place, and over time. So this is not a set life course. And that's very important analytically also when we look at data. So first I'm going to show, these are data from the NSS, the 75th round, just to give a sense of the gender sort of specificity of women's health issues over the life course. So what we see around infancy up till adulthood, we're reporting morbidity at very similar levels between men and women in terms of recent morbidity. Recent morbidity in the last 15 days. But when we move to the middle age and senior older women, first of all, we see a rise, of course, in the prevalence of morbidity, period prevalence, but we also see something interesting happening around middle age, and I'm going to focus on that age group. When we look at the prevalence of these top 5 ailments within the age groups, again, if you focus on the bars on the very outside, again, it encapsulates and I think demonstrates what we hear about the double burden and the changing burden. But the changing burden isn't just over time chronologically. It's really important to remember it's actually within the life course. So it's a changing burden within a woman's life. And what we see here is that all of a sudden, when we get to the middle and older ages, we see that combination of both communicable disease and non-communicable disease still affecting. And the vast majority are for cardiovascular, endocrine, metabolic, and nutritional. Just a data point to note, and I find this always fascinating, that despite this being focused on women, gynecologic ailments are not actually a category, and it gets to be wrapped up with either pregnancy or sometimes injuries. So that's just important to note. We also see geographic variation, calling to what Nandita had brought out in reporting of morbidity. Now, that's a much longer conversation that I won't get into here, that intersects again with norms around reporting, literacy, etc. And I won't get into here except to just note that there is major geographic variation in terms of what is reported, but that variation also plays out with rural and urban populations in terms of what they're reporting and at the levels at which they're reporting, as we see. If you look at those last bars in particular around women 60 and above. So taking that, this is a model that I think is really useful to think about the specificity of women's health. And this is really looking at women's health from biological sex, not necessarily just gender influences, but really thinking of sex specificity here. So if we look, this is a model developed by a group that has been looking at life course approaches, thinking about reproductive health events in lives and then their influence on cardiovascular outcomes in particular, but really NCDs as a whole. And this is based on looking at the Australian Longitudinal Women's Health Study, which is the longest longitudinal women's health studies in the world. And what they found in those letters actually symbolize analyses that have been done and the data have consistently shown that, for example, the age at your first period is directly correlated to outcomes related to breast cancer. Now, these are things that are new. They're emerging really only in the last decade, but very important to make those links between, again, biological factors, as well as sort of life course events, and then the risk of subsequent disease. So I'm going to use that to then really focus on one specific sort of, why am I going backwards? I'm so sorry. Why is this going backwards? Okay. To then really use this life course approach to think about the case of early hysterectomy. And because the focus of my other two panelists is on insurance, I'm specifically not talking about the insurance and hysterectomy story, because I think that's been rather well reported and talked about, and we could have a whole nother discussion on it, but I'm purposely not doing that. But just to remind people, about 10 years ago, there was this huge and continuous media coverage around this idea of needless hysterectomies, a lot of it pointing to RSBY. A closer look at the data actually tells a much more nuanced story, but it's important, and I think this quote encapsulates it, which is to study the indications for hysterectomies, to study the interface between medicine and society. And that comes from England in 1997. This has been a story that has been the case in England, in the United States, in Australia, in many parts. And now we're seeing this story play out in India. When we look at why women are getting hysterectomies, it really tells a much larger story of women's health in terms of their interactions with the health system. So what we know in India, and this is based on the NFHS, the last round NFHS 5, is that the prevalence of hysterectomy is particularly high in 5 states. And if you see, well, these are the top 4 actually right here. I haven't put in Ladakh, but Andhra and Telangana, if we look at women who are currently 40 to 49, 1 in 5 women will have already had their uterus removed by the time they're 50. followed by Bihar and Gujarat. So you're seeing a high prevalence, and these prevalence figures, I would say, are as high as or as higher than many countries that are high income settings. And we've seen actually decline in hysterectomy in high income settings as alternative treatments have really become available. So what we're seeing in India is, again, use of hysterectomy amongst younger women, specifically in states, in particular states. Now, the insurance story, just to flag it here, is probably a story around Arogyasri, pointing to Andhra and Telangana in terms of why that has been happening over time. But the rest are actually quite puzzling as to why specific states are higher than the others. But what is most concerning is the age at hysterectomy. What we're seeing is the average age of a woman undergoing hysterectomy is 34 years. This is at least 14 years younger than the age of menopause, which means these women, if they're either going into immediate menopause at 35, if the ovaries have been removed, or if not, it's hastened quite a bit. And recent data really show this. So we're talking about women without estrogen for a good 15 years before menopause. And that's really important when we think of cardiovascular risk. So going back to the life course model, which we'll do in a minute, is that cardiovascular risk globally actually becomes equal for men and women post-menopause, but before that, estrogen is protective. But what we see is when women are essentially entering menopause 15 years earlier, we will see over time a shift in risk factors as well. Now, what we know is, why is hysterectomy being done? What is the actual health reason? And the primary reason is excessive menstrual bleeding. Now, this is a gynecologic ailment that is incredibly common. And again, it speaks to the idea of barriers to access for basic primary care, for particularly primary gynecologic care, because rather than have access, rather than be able to access a female gynecologist and to be able to access a treatment like a hormonal IUD, for example, hysterectomy has become this sort of primary or second line treatment for women, particularly for menstrual bleeding. And this remains steady through the age groups. And if you look at the other reasons, which are more common reasons, typically in other parts of the world, cancer, for example, or even fibroids or cysts, it is much lower. So what we're talking about here is really not a story of a surgery, but we're rather talking about lack of access to a primary treatment for gynecologic ailments. And what we do find, and this is not surprising, but in the high prevalence states, it's primarily being conducted in private facilities, except in Gujarat, which mirrors the national average, which is about 2/3, a little less than that, in private facilities, and the rest in public. There is a slight age difference there. So the younger women are in the private facilities as opposed to the public. I just want to draw, when we talk about women's health, the links between women's work, labor, and health. And again, hysterectomy brings this into sharp focus, but this is the story for many other ailments as well. And I won't read these, but just to say that a lot of our qualitative research with women who've had hysterectomies really linked it back to work, and the idea that to remove the womb was also to free me to be able to work, particularly for agricultural laborers, because bleeding is really difficult, particularly when you have excessive bleeding and difficult bleeding. It's just really a relief. And the words and the themes that kept coming out were, in a health system without access to other treatments, this becomes pragmatic. From the doctor's point of view, it is prophylactic. Oh, I'm preventing them from having to come up for follow-up. It's preventive. Let's say, for example, from ovarian cancer, which is quite low, but that is the sort of mentality. And also that it's a permanent solution to women's gynecologic problems. And again, I think this in of itself tells the story that you were just telling around access and the barriers and the sort of delays that women face. And what happens is, this is an extreme example of, it's just easier to actually remove an organ because we don't have a health system that caters to women beyond reproduction. So typically what we see is, after women complete childbearing, and if they've either undergone sterilization or not using a form of contraception, there's no access to gynecologic care or to sex-specific care in the system, and we know that. So again, this is all linked, because not only is the reproductive health event there, the age at menopause being shifted to the left, what we see globally, and again, all of these data have emerged in the last decade, is that women with early hysterectomy, and I specifically say early hysterectomy, so premenopausal, there are very strong data from longitudinal studies globally that show an increased risk of cardiovascular disease, all-cause mortality in Australia, osteoporosis, urinary tract disorders, and mental health. So we are seeing that clear link between the removal of an organ and all of the NCD risk factors that Nandita spoke about. There is a very sex-specific link in women that is not there in men due to hormonal factors. Am I okay on time? Okay. And what we found from last, these are cross-sectional data, so not as strong as those longitudinal studies, but we did find correlations that women who had undergone hysterectomy had higher odds of hypertension, diabetes, and bone and joint disease. So we are seeing already in India the science, if we were to take that, knowing what we know of the age at hysterectomy, as well as what the global data show, I mean, I think we have a pretty strong argument to say that we're seeing very similar patterns here. And these are really disturbing because these women, remember, are in their mid-30s when they're undergoing the procedure. So why does it matter? I think it's obvious, but still that, of course, it's for women's health and the increased risk of NCDs, but also how we think about women's bodies and interventions. The idea that a permanent intervention is a sort of practice of choice in several states, and we're seeing it sort of expanding across other states in South India, for example. It tells a story of social norms, of course, and medical interventions. I'm really sorry, something's happened with the uploading, so all my formatting's changed. That's why the words are strange. And of course, around health systems, there's a story of equity because the variation we see across the country, in a state like Meghalaya, for example, the prevalence is very low, it's 2%. So there might also be a story of lack of access to some of these basic procedures as well. And of course, ethics around information on the side effects of a hysterectomy, but the ethics around what are the options? Are there any options available to women in the system? I'm going to end with this, going back to my first point on the life course, which is that, the life course is thought about in age, but in India, oh God, this is terrible with the change in formatting. But basically that 19 is there. So a woman would go to pregnancy at 19, sterilization by 26, hysterectomy at 37, you're talking of a completely shifted life course where the postmenopausal years, which are typically after 49, are being shifted a good decade and a half earlier. So when we think of our analyses of women's health and think about women's health in the life course, it's important to retain the specificity of the specific life events that we're dealing with. And I would just want to argue, and this is something I was telling Anjana in the beginning when the national guidelines on hysterectomy emerged and we were trying to figure out, well, who is the nodal body within the government for these guidelines? These are really important new guidelines that have been notified in 2023. And in maternal health, they said, well, it's not maternal. NCD mein chale jaiye, I was told. But it's not an NCD either. And then to me, it illustrates exactly our point around the need for women's health strategy and the idea of women's health policy rather than maternal health or NCDs, but these are really all linked. And it's time we start thinking about, of course, the sex and gender specific data and access to treatment, but really shifting our thinking around women's health through the life course from a policy perspective as well. And
a very disciplined set of speakers. Everybody's on the dot, 15 minutes again. But thank you, Sapna. Some very disturbing data, but also, for highlighting how one situation is impacting other health concerns and economic issues as well. So over to Radhika, who will now run us through the utilization of hospitalization through health insurance. Radhika?
Great. Thank you so much for inviting me to talk about my research here. And it's really great to see some of the the first two talks. I think there are similar important themes coming through all of them, including I appreciated the focus on NCDs as opposed to just MCH and looking at older women. And just a small note, there's a paper that sort of quantifies excess mortality, missing women in India and shows that CVD is one of the major sort of causes of it. So causes of excess female mortality in India. So that very much echoes things that have been said earlier. I'm going to talk about gender inequalities in health insurance usage, and this is based on a paper that is jointly written with Pascaline Dupont at Princeton. So once again, India has sort of consistently ranks amongst the bottom 5 countries in the world for female health and survival, which was actually a statistic I did not know and surprised me. And, there's a large amount of research now that talks about gender bias in health inputs that contributes to worse female health outcomes, including, substantial excess female mortality. The last estimate in the same paper that I mentioned, 63 million missing women. What's less well known is that the majority of those missing women are, at older ages, and not so it's not just sex-selective abortion that's kind of leading to this. And, subsidies kind of are thought of as a major policy to reduce health inequality. And as has already been said before, in India, in the last decade especially, a lot of this is being delivered through the mechanism of government health insurance. And these programs essentially sort of provide, entitle low-income households for free care at both public and impaneled private hospitals. And now the PMJ program is, has been rolled out nationwide, pretty much, and aims to cover the poorest 40% of the Indian population. And as Nandita said, these government health insurance programs are a key component of the country's kind of UHC policy, and ensuring, in universal equitable access is an explicit goal of these insurance programs. And so kind of our paper tries to look at this question and say, does subsidizing hospital care through these insurance programs actually reduce gender inequalities in utilization? And I'm going to start with some descriptive facts from about the program, and then go into a little bit more causal work. So just very quickly to give you, this is the program I study is before PMJ was launched. And so this is the BSBY insurance program in Rajasthan that was launched in December 2015. Covers about 46 million, at the time, covered about 46 million poor individuals, and people were automatically, learning from challenges in RSBY. They did away with enrollment processes, so you're automatically enrolled based on your BPL status. There's no premium or copay. Care is supposed to be completely free at the point of care, receiving the care, and the hospitals are sort of reimbursed by the government for the services, and the reimbursement is supposed to cover everything: tests, medicines. So it really was trying to increase access for everyone. There were about 1,600 hospitals in the program at the time of the study, 2/3 of which were private. And just to give, so the typical hospital in the program is something, this is a photograph I took maybe an hour outside Jaipur. And very briefly, the data, again, like Nandita, we were able to get the insurance claims data from the government for this, which was incredibly valuable. It's some of the most granular, it is the most, I think, granular hospitalization data in the Indian context. And so we have the insurance claims for every hospital visit in the first 4 years of the program. That's over 4 million hospital visits. And as granular as it is, the information includes patient age, sex, phone number, a little bit about the hospital, and then the service code. And we used, to make sure, because administrative data often has problems, we did surveys, with patients soon after they're using the phone numbers, and verified that the female status in the claims data is in fact quite accurate. And because for this analysis, we're kind of comparing male to female usage, we kind of exclude the first year, which had the more problems in the data, as well as childbirth and infant claims, again, for various reasons. And then taking the, patient residence, the addresses, as well as the hospital addresses, I spent a very large amount of time cleaning that up, and then geocoding it, linking it to census locations. And so that allows me to look at sort of, where people are, how far people are traveling, and what the distance is from a person's residence location to the nearest hospital in the data. So moving on quickly to results. So this is the first, literally plotting the female share of hospital visits. That's the height of the bar by age group along the x-axis. And what you see is, overall females account for about 45% of visits, but you see really large disparities amongst children. So under 35% of all hospital visits for young children under 10 are for girls. And the other big area you see big disparities is amongst elderly women, where again it's about 40% of all hospital visits are for the elderly, and I think and this has kind of now come up again in the previous things that like. Yeah, when women of childbearing age and children get a lot more attention in policy circles, these large, the gender disparities in healthcare usage for elderly women is not something that gets as much attention. The other thing that is worth saying is, even amongst women that are 20 to 49, a lot of the care that is kind of driving this female share up here is linked to, it's around pregnancy. It's various services are related to childbirth, and it does not, just because it's close to 50% here, does not mean that these women are getting all the care they need, especially in domains outside maternal care. We do lots of things to sort of dig into what could be explaining this gap. The red diamonds here are the female share of the population, and there is some imbalance, especially amongst children. There are missing girls, and yet the female share is slightly under 50%, but it's far smaller than, the disparity in the population is not enough to explain the disparities that we see. A different question you might say is, well, maybe it's just that women are less sick, women and girls. And so what we do here is to, and maybe 50%, maybe half is not the right benchmark. So what we did is actually take the global burden of disease data, again, very helpful to have that. And in the red squares, I've got the female share of, the incidence. In a way, you'd want to think about this as if... so for example, in the first panel, we've got from the global GBD, we've got the female share for each age group of all, estimated share of all chronic kidney disease. And then in the blue bars, there's the female share of hospital visits in BSBY for chronic kidney disease. And again, what you see is just really startling gaps. So, so for example, if you look in the final column of the first panel, about 55% of all chronic kidney disease cases are estimated to be for females in the, in terms of incidence based on the JBD, but only about 30% of all hospital visits for people over 70 years old in BSVY is for women. And so again, differences in illness prevalence cannot explain the differences in gender disparities in hospital usage that we observe. And we do a little bit of a, sort of back of the envelope kind of calculation, putting these numbers together, and essentially find that, if we estimate that there are about 200,000 missing female visits for nephrology, cardiology, and oncology alone. So this is if women were getting care to the same extent that men are, and not all the care they need, but just if they were treated conditional on their being sick, if they got care, hospital care to the same extent that men did, we would see 200,000 more visits for women. The other sort of startling descriptive fact is how this changes over time. So the blue bars are the total number of hospital visits. 2019 is not, we only have data through October, so that's why the bar is a little shorter. But what that shows you is that, there's the number of visits annually is increasing substantially over time. So the program is expanding. People are learning more about it. People are using it more. The black line, however, shows you the female share of visits over that same time. And what's sort of startling is, that corresponds to the axis on the right-hand side. So it starts out at about just under 48% of hospital visits are for women, and this drops, even as the program expands over time, the female share of visits actually decreases down to about 44%. What this also implies is that, the gray dashed line is the female share of program spending, all the money that the government reimburses hospitals. And so sort of, it kind of makes sense that because of these gender disparities in utilization, what this implies is public spending on the program is quite male skewed, and overall under 40% of all insurance spending is by the government is for female care. And then the last thing, I just want to sort of show that these are the female share of visits by specialty. And so this kind of shows that general medicine is where a lot of the maternal related care services come, but even there, it reaches 50% around there for ophthalmology, dentistry, and general medicine. But, the gender gaps are substantial across quite a lot of, it's not just one specialty that's driving this disparity. And echoing things that have been said earlier, you can see that there are particularly large gaps around cardiology, nephrology, orthopedics, which are sort of repeated services, more complex services. And yeah, okay. And so the next kind of a set of results I'm going to look at, show you, is that we find evidence that, many things go into the gender disparities and might go into the gender disparities in usage that we see. One thing we try to show is that care costs are one of the factors that are associated with larger gaps. So this is based on survey data. So we conducted surveys with people soon after they visited the hospital under insurance and asked them if they paid anything out of pocket. And then we kind of quantify the amounts of the average payment, the payment for different services. Keep in mind that this is supposed to be care that they got under insurance, at a hospital that is insured. The hospital has been reimbursed by the government, and still they are paying out of pocket for care that's supposed to be totally free. So this is not because they're not covered, they don't have access, and so on. It is literally because the hospital is charging them. And I've kind of circled that vaginal childbirths, they pay about roughly 1,500 rupees, where keep in mind, this is in a context where women are, not only is care supposed to be free, women are supposed to be paid to, deliver at the institution through JSY at the time. And then the other, I'm just kind of highlighting angioplasties. The sort of broader pattern is that the more complex care, the more complicated services, out-of-pocket charges are higher for more complicated services. So overall, the statistics are about a third of patients pay. The average payment is about $30. Sorry, this was first written for a US audience, but it doesn't seem like that much, but it's a 35% markup over the reimbursement rate that the government gets from the hospital. And as I said, the more complex services are associated with higher charges. And the big thing we show is that higher charges are the more a hospital charges for its services. So using male payments as the benchmark for how much a hospital charges, we show that 1,000 rupee increase in a hospital's charge for a service is associated with a 3.5% decrease in the female share of patients visiting that hospital for that service. A different type of care cost we look at is distance. So, distance, the further the distance, it's quite sort of generally accepted that the further the distance you have to travel for your care is the higher the cost of it, in a sense, right? Because there's the cost of the travel itself, the time you have to take off, and so on. And once again, we show each of these lines is the female. So when, across the x-axis is the distance from a village to the nearest impaneled hospital. Going from 0 to 25 kilometers, and each of the lines I'm plotting is the female share, how the female share of hospital visits to BSVY from that village kind of changes with the distance of that village to the nearest hospital. And once again, we find, and we do this is just sort of descriptive, but we do it a little bit more carefully in the paper. Essentially, a 10-kilometer increase in the distance of a village to the nearest hospital is once again associated with a roughly 3.5% decrease in the female share of BSVI visits from that village. What we also, this is just, on the sort of whether or not, affecting the probability of getting any care. We also look at amongst people who do get care, we show that, households travel further for male care than female care, again, sort of indicating that they're willing to pay more for male care. And we show that even in the same household, people travel further for male care. And finally, we show that households are traveling further for male care, even amongst children. So they travel further for their male children than their female. And the reason the sort of results around children is important is, I mean, all of this is kind of coming together to say, to show that, you know, households are willing to pay less for female care than for male care. But, you know, you might say things like distance. Well, there are, you know, it's just harder for women to, you know, distance has a different kind of cost for women than men. But when it comes to the child, you know, the child is not, who takes the child to the household is independent, should in principle be independent of the gender of the child. So the fact that you're seeing big gender disparities amongst children in whether they get any care and how far households are traveling for that care, you know, much more clearly indicates evidence of sort of biased decision-making within the household, and not just the specific barriers that women face in getting care for themselves. You know, I think, I know I'm running out of time, so I'm just going to kind of, I think I've sort of said that we find the gaps are larger in tertiary care than secondary care. The gaps are also substantially larger in chronic, particularly oncology and nephrology than other services. Again, all of this is sort of consistent with how, you know, these are services that tend to have higher out-of-pocket charges, higher distant travel costs, more, you know, again, consistent with households being less willing to incur costs for females than males. So, you know, essentially the kind of summary here is that in a gender-biased society, you know, demand or willingness to pay for female care is lower than for males. And these insurance programs, you know, subsidize but do not eliminate care-seeking costs. Even if they manage to make sure that the hospital doesn't charge anything, there's the cost of travel, foregone wages, and so on. And so, you know, because of this differential willingness to pay, any care-seeking costs, you know, differentially deter care-seeking for females more than for males, resulting in gender disparities. So then the last, you know, the last bit I want to touch on is, okay, so, you know, it kind of begs the question, well, maybe, you know, I've now shown you that higher costs are associated with larger gaps. Well, does reducing the costs reduce the gaps, right? It sounds sort of intuitive, except that you should already be thinking no, because to some extent, this BSBY program has already started reducing, you know, subsidizing the cost of care, and still we see gender disparities. But maybe it's an improvement over what it was before. So in this piece of the part of the paper, we kind of try to look at find a way of saying causally, when you reduce the cost of care seeking, when expand access, what happens to female relative to male utilization. And so the way we do this is there was a big administrative push to increase access and impanel more hospitals in early 2018. And so what that does is by impaneling a new hospital in the program, you're suddenly reducing, you know, for a village that didn't have a hospital nearby, now suddenly there is a hospital that's nearby. So, you know, essentially you're reducing the distance cost of using BSBY from that village. And on average, and so what we do is we compare villages, you know, starting with two villages that don't have a hospital nearby. One of them got one through this impanelment push and the other didn't. And then we can kind of compare changes in their outcomes to see what happens when the government expands access and essentially reduces the cost of care seeking further, or in other words, increases the subsidy further. You know, on average, this resulted in a sort of 20-kilometer decrease in distance for these the hospitals that the villages that we study, which is about a 60% decrease in the distance. So the main first result is that, you know, in the blue bar, you have female visits from these are quarterly village visits to a hospital under BSBY before and after. And there's a large, you know, 15.5% increase in female visits from a village when they get a hospital impaneled nearby. But there is a 19%, you know, male visits were higher to start with, and the increase that they experience is also larger. So essentially, you know, reducing the cost, expanding access, improved outcomes for women and increased their likelihood of using the program, but did so more for men in the same village, and as a result did not reduce the gender gap at all. And so then you say, how do I square these two sets of results? You told me that care costs are associated with larger gaps. Now you're showing that reducing costs does not reduce the gap. How does that make sense? Well, if you had a static pool of people, yes, willingness to pay for female care is lower. Reducing the cost of care does induce some households to now start being willing to seek care for females as well, which is why you see the increase in female visits. But the program has not, because reducing care also induces new households to now start participating and getting care that, households that couldn't previously afford it now, BSB-wise, maybe more affordable for them. And they are, now they are more likely to bring their males in first. And so the kind of net effect of increasing subsidies depends on which of these two effects kind of dominates. But the kind of implication is that increasing subsidies, reducing care costs benefits women and enables households to seek more care for women. But, benefits may benefit men more. And to get to the point, to meaningfully reduce a gender gap might require a very large subsidy. And so, the sort of implication here is that program expansion, subsidy expansion alone is not necessarily sufficient to reduce disparities. And this is very consistent with the descriptive statistics I showed you over time, that even as the program was expanding, female usage was decreasing over time. And that's kind of, let me just kind of close. There's another piece of the paper that I don't have time to get into, but one large, we sort of echoing previous research, we show large gender disparities persist within a heavily subsidized UHC program. In the presence of gender bias, demand for female care is lower, which means that any care-seeking costs exacerbate gender disparities. The really core point I think I like, to make out of this paper is that gender-neutral subsidies are great. They increase female usage of hospital care in this context, but may not reduce gender disparities and could sometimes increase them because males benefit as much or more. And that actually achieving parity is going to require gender-targeted interventions that specifically, essentially the gender-neutral subsidies means everybody benefits, including males. It's much harder to close gender gaps. To close gender gaps, you're going to require much more gender-targeted interventions that specifically address the barriers and costs that females face in care seeking. And in the last piece of the paper, we actually show some evidence of this. We show that, areas that have female political representation there is some closing of the gender gap because those female political leaders specifically do things that target the barriers that women face. So I'll stop there. Thanks very much.
Thank you, Radhika. That was actually very insightful, especially the part about how the gender-neutral subsidies aren't really impacting the reduction of gaps. And I wonder if, a change in the profile of the health workforce may have some dents into that. We're now going to move on to Anjana to share her thoughts, her observations, and maybe some controversial comments.
Okay, thank you so much. And thank you to CSEP for inviting me here. I'd like to thank all the three presenters for their very rich papers, which taken together, I think, make a very substantial contribution to the field of gender and health in India and open new and emerging issues for inquiry. They've also, all three papers have deployed creatively the use of frameworks like the 3 delays framework, or in the last paper by Radhika, she didn't get into it, but she uses this very interesting framework of differential costs, differential returns, and bias. And you saw in Sapna's paper the life course approach and how it needs to be more specific as a model, not just based on ages, and also a variety of methods and data sources that we saw. Looking at these three papers, and I read them, which some of the parts of the papers haven't been gone into in great detail. I was struck by several points, which I will now try to put before you. One is all of them talk about the differences in their
in their findings by socioeconomic status, by states. And so I think that points the need for state-specific or context-specific solutions. Another, I think it didn't come out so much in the presentations, but when you look at the papers themselves, the importance of an intersectional lens in analysis. Because in addition to gender, you saw other factors playing in to produce the findings that we're seeing. For example, the social norms that favor household investment in healthcare for men and boys over women and girls may be compounded by, say, poverty or rural residence or lower education. And we saw some of the factors in your paper, Nandita, which you didn't get into, about what improves women's agency and empowerment and how does that lower women's barriers or gender-specific barriers. And so that intersectional lens. And similarly, we saw in Sapna's paper also factors driving early hysterectomy include the labor market and women's compulsion to earn wages at lower ages. So what does this all imply? Number one, I think the big story, I think, coming of these three papers together is around the epidemiological transition and the need to look at women as whole beings and not just as reproductive creatures. And so we value them as agents or as clients of the health system, we do need to look at all their health needs and not just their role as reproducers. We also saw, in fact, a clear link between reproductive health issues earlier in life and the emergence of NCDs in later years. So this, I think, is a really important story with very important policy implications. Our own analysis when I was in WHO that we did for countries across the region showed that where NCDs are concerned, you had gaps by sex starting from symptom recognition, screening and diagnosis through to getting people on treatment, say like for hypertension or diabetes, and then effective management and control. So there was a falling off by sex at every stage of this pathway. The other story, less emphasized in these presentations, but also striking, is the demographic transition and the healthcare needs of older women. And what is the role of gender in accumulating disadvantage for women over the life course, so that when they enter old age, they're entering it sicker than they need to be. And also the accumulated disadvantage poses gender-specific barriers to their access to needed health care. We also know from global and Indian analysis that there is a feminization of aging. In other words, women predominate in the older age groups, and the older the age group, the more the proportion of women. So basically, they're living longer but unhealthier. They're also facing a care burden. They typically care for their older spouses in old age and for younger people in the household. And they outlive their older spouses, raising the risk of dependency and lack of needed care. So what can health policies, programs, and systems do? I think we saw very strikingly that gender-neutral policies are not going to be the full answer. I mean, increasing subsidy, as you saw in the last paper, or increasing availability will go part of the way. It will improve access for women, but not fast enough for them to catch up or to close the gap. And in fact, it may increase the gap. And there may be male capture of the additional. So in other words, in the language that we use of gender blind, gender neutral, gender responsive, we need gender responsive and gender specific policies. Within the health system, I think there are lots of lessons or pointers from these papers around a whole of health system approach. In other words, an insurance subsidy-based intervention needs to be complemented by complementary actions across other health system building blocks. And so starting with health financing itself, we saw that in addition to free healthcare, targeted subsidies may be needed to close gender gaps, for example, around transport costs, or you could think about cash transfer type incentives to close the gaps. Then increasing the gender responsiveness of healthcare providers. For example, we saw the lack of women providers was one of the barriers that women reported. So improving their availability, the proportion of women providers, but also improving their attitudes. On the service delivery side, integrating or modifying service delivery, for example, using points of women's interaction with the health system to tackle their underserved health needs. So if they're coming in for their children's ill health or their own maternal healthcare needs, these are important contact points to begin exploring and serving their other healthcare needs. Also, better links between primary and other healthcare levels of the system, because you want to prevent breaks and tackle the ongoing chronic healthcare needs, particularly using mobile health technologies for women who own phones could improve their knowledge, their awareness, and also could trigger them to seek needed care. We also, I think the papers hint at the need for gender-focused quality improvement approaches, less provider-driven unnecessary care, more respectful care, provider and facility-based monitoring through these very rich data sets from the publicly funded health insurance programs could, against and measuring the providers and the facilities for unneeded care against norms could perhaps put a damper on unneeded care, like early hysterectomies. But these also need to be complemented by gender transformative approaches to counter or transform the kind of persistent gender inequalities at the household and societal levels that we saw in these papers. For example, increasing the agency or the empowerment of individual women. And that was a part of the paper that Nandita could not speak to in detail, but they show that education, income earning, mobile phone usage as proxy for empowerment actually is positively correlated with increased access, but also at the community level. And the last paper by Radhika, the part she wasn't able to speak to, was about improving political representation of women and how that over a decade was shown to close the gender gap through the actions of women sarpanches and panchayat members. Then on NCDs, because on NCD prevention and management, there is a whole gender agenda to be addressed. In both in primary prevention and in secondary prevention. Some research, for example, points to how gender operates to lower women's and girls' mobility and physical activity due to safety concerns, but also restrictions around their mobility overall. And so if they have lower physical activity rates, their risk for primary risk for NCDs goes up. For secondary prevention, it would be the gender barriers on that pathway that I described, from screening to diagnosis to getting under treatment, and then to be effectively managed so that it doesn't lead to, say, hypertension doesn't lead to a cardiac event, or high blood pressure doesn't lead to active diabetes, and so on. A related research question, I think, is so the papers talked about gender-related barriers to access to services, but when you are in an era of NCDs, you have chronic health needs, you have long-term and an ongoing engagement with the health system. So I think a very important research question would be, how do these gender-related barriers constrain women's access in this long-term healthcare need scenario, as opposed to, acute or episodic illness needs. For older women, as I said, I think these papers are opening the door for a big policy agenda on gender-responsive health policies and social policies for older women, influencing the way the social determinants act throughout the life course to ensure that women enter their older years healthier than otherwise, but also once they are in old age, what is the disease prevention agenda? There are some low-hanging fruit, for example, eyeglasses, reading glasses. Older people will have reading vision loss. So something very simple can improve functional ability despite intrinsic capacity decline. And then my last, hopefully provocative thought, I think these papers reinforce what we know is that addressing gender issues in health is a complex business. It's a long-term business, and it's political in nature. And I think that this complexity needs to be embraced. It needs to be acknowledged. And there is a need for not just one intervention, but perhaps multi-component interventions at multiple levels, at the household or individual level, at the community level, and also across groups of stakeholders beyond just government. So I'll stop with that. Thank you.
Thank you so much, Anjana. That's a great set of takeaways. And the one thought that's coming to my mind, listening to all of the pathways that you've identified coming from these three presentations, is your last point on the politics of actually moving towards gender equity. Because it's not that some of what was, the inequities in health and other sectors, they're not unknown. And yet the steps that need to be taken are not taken. Why is that the case? And is putting forward the reform ideas, or the technical ideas, or the program ideas enough? Is it that our governments, it's not just India, many countries don't quite see the incentives of actually investing in women's health? And what are the kind of incentives that will, I'm tempted to say, wake them up and say, this is important? But that's another discussion for a whole day. Let's open it up for questions. We have about 12 minutes. So, Priya.
Hi, thanks, Sandhya, for inviting me. This was really a lovely panel. I think one of the issues
Sorry, can I interrupt? I was told today this is the first all-women panel at CSEP. We've never had a seminar with all women, so
I did notice that. Congratulations.
I didn't know that, so I was
No,
told
I don't know about
it's the
CSEP,
first one,
but
yeah.
I just like the fact that it was all women.
Sorry for
Of
interrupting.
different shades and colors. No, so one of the thing I feel, and maybe it would be most pertinent for Radhika, but others may, is, you talked about the context. A lot of the data kind of invisibilizes the context. And so women who are coming from lower socioeconomic backgrounds are actually paying a lot for healthcare, multiple providers of informal nature before they may actually seek the point where it's hitting your data sets that you're analyzing. And so I think when you're saying the expenses are less, firstly, one of the big factors is most of the expenses are out of pocket. So women may be paying much more out of pocket that on health that they can ill afford. And perhaps what we also need to look at the counter side of this, loans, informal loans, the number of episodes of illness, the number of visits per illness at the informal level between men and women. And there are studies, so one can at least harvest the data that exists to contextualize that there's also this parallel economy of health, which we are not getting to. And the other part of it is the reason why is trust, right? So you may not get the kind of absorption or utilization because you don't trust the system, while what you trust is what is close, what is proximate, what you know, where the provider is talking to you in ways which seem more familiar or comforting, so to speak. So I think for me, that's a very important issue which hasn't come up, and I'd love for you to talk about how would you build that into your analysis. And the second thing is just I agree with everything all of you said, But on the life course perspective, I think gender-based violence is such an important, and there's so much data that is available on that. So it's not just an event, it's the whole life course of violence that is accompanying women's journey of morbidities. So I would urge you to kind of please bring that into the framework that you can adapt, and because and there are other data sets. And I think for me, the other thing which is really important on the life course is just understanding we don't have enough from LMICs on brain. We don't have enough data on adolescents, girls, studies of what context and adversity does to girls' cognitive and other behavioral development versus boys, and how that then lends itself to mental health and other kind of psychological burdens which are not even counted. Like, yes, we are broadening this from maternal health, but then there's this whole other spectrum of health that we're not even looking at. So just wanted to offer that. Thanks.
Thank you, Priya. As you were to your last point, I was thinking maybe a female equivalent of the show Adolescence. I don't know if any of you have seen it, but yeah, it's very disturbing. Anyway, we'll take a couple of questions and then request the panelists to. Indrani? Akila? Sorry, Uresh? Oh, Priyadarshini. Sorry.
Hi, thank you for a very interesting discussion. I'm actually thinking of the last point that Sandhya mentioned around the politics of prioritizing women's health needs and generally the health agenda, and what that politics would look like and at what level that politics has to happen. And my sense is that invariably the focus is a lot on state level or national level large policy initiatives as a space where prioritization has to happen, and it has to reflect in schemes and initiatives that the government has to take. And I'm wondering whether that may actually be debilitating the agenda, and what really is needed is a focus at the primary care level, because that is the space where a lot of your transitions in health, whether it is about women or it's about children or men or whoever, should sort of play out. And the system's capacity to communicate that changing health agenda from that level has to go up. And when we are talking about that, the politicians have to sort of be aware that this is important. A politician is unlikely to really understand how complex a health agenda is going to be. But a politician has to be aware and responsive to the needs of their constituents. And the spaces where a constituent could sort of communicate this is in the interaction with the primary care level. So what we really are seeing is perhaps a problem is that the whole health system has gotten lopsidedly dysfunctional, and which is why we are seeing this sort of systemic stress where, politicians are coming up with insurance-based plans, not because they sort of are not doing the job of prioritizing something that's social welfare and important, but because as a leader at a state level, that's all you'll do. You'll say, oh, this is a problem, so let me come up with a thing that can be fixed very easily. Whereas the problem perhaps far deeper is within the health system, that what we really need is a closer interaction, a more deeper, frequent interaction between people and health providers, which has to happen as a primary care level. And then that system sort of playing that role to consolidate the agenda, to mobilize different segments within the health and the non-health sort of sectors, which is, at least in my research, I'm feeling is absolutely not happening. There are no channels where you discuss health as an issue that belongs to the society and to the health facility in a sort of less trained technical manner. It's always so technical that mobilizing work, the agenda making work, is not happening, and it's kind of gotten devoid from its social and political sort of broader context. So I was just wondering whether that is really the issue rather than politicians not prioritizing this.
Thanks, Priyadarshini. Very important point. Anybody else? Okay, someone at the back. Yes, please.
Great clarification. Thank you so much. I think even I one of it does not look at the disease specific programs which are designed around then the people specific any of the countries, if you would like to highlight upon. The second point, and this is my last point, is is basically, the entire the system level, issues when we talk about the service delivery. I think quality plays a very critical role in, the hysterectomy cases which you mentioned. Probably, it's a lack of quality. That's the reason why, the patients are treated the way they're treated, right? So in any of your studies, have you also tried looking at any of that element? Thank you.
Thank you, Anurag. Yes. Just one point. I mean, I don't know whether you know, there is a data set, multi-state data set exists on women's empowerment in nutrition index, very done. Sudha and Erin has done. And there, there have nutrition has been in 3 domains. One is food intake, one is health, and one is work. And so health captures all sorts of health-seeking behavior. And just as women distribute the food but eats last and the least, so healthcare also same thing. The healthcare seeking behavior is always informal and all. And it has got several 5, 6 states data. So you could look at it. I think it will be available. Great, wonderful. Shall we move to the presenters for some responses? Anybody, whoever wants to respond to any of the questions. Radhika, since you're online, I don't want to put you in a spot, but.
No, that's fine. Thanks. Okay, so to the point about that women are paying out of pocket for informal care well before we observe them in the insurance data. That's absolutely, I think that is true and that's right. I don't, but it's in no way a sort of substitute for what we should be seeing at the hospital level, right? Like keep in mind that the big disparities we're seeing are in things like nephrology, dialysis. If you can't get dialysis at an informal provider, and without it you die, right? Oncology and things like that. So I think it's true that sometimes households are substituting informal care, and sometimes households are, and then for hospital care and maybe doing so more so for women. But I think that's consistent with women not getting the care that they should be getting. So I think, and on the second point about localization, I want to echo that. Like, I think, of course you need national policies, of course you need state level policies, but I think what's kind of come through in all of our talks and as well as Anjana's comments afterwards is that the sort of response, gender sensitive responses and, policies are going to require quite a complicated, and probably context-specific set of sort of interventions and actions. And I agree that some part of this is going to be about primary care, and that links to the point that was made about trust as well, is that if you can have a strong primary care system that can kind of catch and diagnose early and then act as, sort of shepherd women through the health system, that both builds trust and kind of addresses several of the barriers women face in feeling sort of not very empowered and not really sure how to go through the health system. But I think even politically, like I said, the last piece of our paper, we show that female political representatives at the very local Gram Panchayat level can do things, seem to be able to reduce the gender gap. And it's interesting, when I went and talked to some of the sarpanches, the women sarpanches, they say things like, I can go to the household and, convince them, they'll listen to me and I can convince them, basically advocate on the woman's behalf. In a different household's case, they said she needed there was some issue with transport, and so I organized with somebody else. So the point is that again, kind of working at, I think the broader theme I'm trying to sort of both agree with and bolster is that I think it's going to be very difficult to come up with policy instruments at a state level or national level that remove this, but that like the solutions and therefore the kind of institutional empowerment to address this and make this a priority kind of, I think, in my opinion, needs to be much more local, and therefore, that can sort of adapt to the particular barriers that women in particular contexts face.
Thanks, Radhika. Anybody else? Thank you for all of those questions. I'm going to try to address most of them. Priya, to your point on the life course and gender-based violence and also cognitive issues that we don't know, I completely agree. And I think there are life course models that do address these. And I think what it really highlights to me and underscores is we need longitudinal data in India. We don't actually have longitudinal. I mean, last see now is one example of when there'll be a second round, but otherwise, longitudinal women's health data were really the only thing we have to actually understand many of these issues, not just around, I think, physiological, biological, or sort of changes to their body, but also treatment seeking journeys. So to the question of where women go and where they seek, I mean, there are excellent examples of these sort of studies. There's not tons globally that I think we just desperately need to understand many of these issues and to contextualize them locally. To the point about primary care and what's happening at the primary, so we did this evaluation of HWCs and UP and Bihar. And the most interesting thing was the change in when the upgraded sort of subcenter, the upgraded PHC, the HWC, the change in the age profile of who is seeking care. You saw women post-pregnancy for the first time. The subcenters were completely women of maternal age, and all of a sudden you saw this jump, which I thought was fascinating. When there's strong primary care, when CHOs were available, women of middle, sort of in midlife were going to seek care. We also saw more men seeking care in a way because men actually never had a subcenter. And I think that's an important point around gender, is that men said there's finally something for me, because the subcenter, there was nothing. So I think that point, and in addition, in terms of the politicization, something that puzzles me and something I've studied, as Priya knows a lot, is women's groups and self-help groups, and looking at all the different models of women's groups in the country, and why health has not really been a primary agenda, has always puzzled me. It's seen as this delivery mechanism, but rather, and literally last month I was at CSEP, and they were saying they're trying to bring health back on the agenda in Telangana as something not as a delivery mechanism, but rather women who are in the mid to late 30s actually discussing what their health needs are. And I think that's a huge potential that has completely been untapped in a more participatory way rather than a delivery way. And lastly, to your issue of quality and thinking of, again, I think one broad stroke response would be, well, actually, first, in terms of other countries, I think, again, I'm going to say it again and again, we don't have sort of even a strategy or policy framework to think about women in a certain way. And I think what we can learn from, the UK, I think, has a women's health strategy emerged like 5 years ago. So it's not as if everyone's really very different, but there were these really interesting mobilization exercises to get women's voices into shaping those policies. And on quality, I mean, some of the work we're trying to do now, I don't know if they're objective measures of quality, but really are to understand women's experiences through the entire treatment seeking journey, to understand what they were offered at which point and why, to give us a sense. So I think one of the challenges will be, what are those quality measures that would be objective, or at least usable in different contexts within the country? So that's more of a question than a response.
So I didn't have any specific questions to me, but I wanted to speak to a couple of things. One is, I think, Priya, what you said about the pathway, I think that is a really important question. And it's almost like what we call now the implementation science question, is to really kind of understand how you are getting to the provider and what has been your experience. I also feel like the part where you talked about, what are the loans, the informal payments, a lot of the sort of the hidden part of the payment sort of schema, I think it also needs to be related back to the questions around women's labor force participation, which is like a really important policy question today. Because how do you expect women to ask or even demand healthcare when they feel disenfranchised economically within households, right? So I think that is a very important point. Priyadarshini, I think the point you said about agenda setting and losing spaces to build that agenda is so very true. I think it exists not just with communities, but I think even increasingly we have to have more dialogues to make that happen, because that's how I feel like something will move. And because Sandhya wanted a controversy, I just want to say one thing. I just want to say that honestly, these are public funded programs. A lot of data should be public. It's often not. Radhika, I don't know what your experience was, but I think it was very hard getting data. And I hope that changes because I think a lot of it depends on how, many doors you knock and things like that. So I think that data is going to empower us to make better policy. So I think that has been something that I wish would change. And lastly, I just want to say, Anjana, you said something about, there is a very clear gender agenda within NCD prevention and management. And I think that if our programs don't address that, then we are really self-harming in a way. But yeah, that's all.
Thank you.
Good. Actually, Sapna, you made two of the points that I was thinking of making, so we're all covered. Thank you.
So, okay, thank you. We're on time. I think this has been a wonderful discussion. Many questions that were
Highlighted as takeaway, and I think the need to see this not just as health, but the connectivity with the economics. I mean, the economy, politics, safety, all of those. But yeah, I mean, to me, I think the final where the buck stops is the politics of it. That why isn't it happening? But great conversation. Thank you all. Thank you, Radhika. Thank you, Nandita. Thank you, Sapna. Thank you, Anjana.